it would be nice if we can bring some of the updates from the EASD. So to set more context and to welcome all of you formally, I will request Dr. Bansi Sabu, who is the Secretary of Diabetes India and currently the Chair-elect of IDF Southeast Asia, to welcome all these speakers and panelists and initiate the discussion.
So first of all, thank you all the speakers who agreed, including panelists and chairpersons from India and the international speakers and some of the speakers from our country. They agreed just before 7 days. We have written mail. Some of them we called them, and they all agreed to speak on this. The idea of doing after ESD, we know that ADA and ESD are two premium meetings along with IDF, International Diabetes Federation meetings. So these are the three meetings where many of the doctors in India, they always want that they could go, but most of the time it is not possible for every physician. There are more than 40,000 physicians in India who are practicing diabetes, but they may not go and learn many things from ADA, ESD, or International Diabetes Federation. The Diabetes India thought of that we should bring immediately some of the updates or some recent advances. Maybe in panel discussion, we can discuss. Other than that, what topic which our speakers are going to speak. That's the idea of doing this program. Doing a program for 1.5 hours is sufficient because a span of more than 1.5 hours, again, it is difficult for audience to listen and to catch them for longer period of time. 8:30 to 10 o'clock is the time when after their clinic, they can listen. Even we advertise it only today, but today also more than 1,200 doctors who are going to join for this meeting. So we have a good number of doctors or attendees who will be there for our today's session. Diabetes India, most of those who are from India, they know that this is an organization started almost 25 years before. We are doing a lot of international collaboration. And this time in ESD, we were having not only our symposia of Diabetes India, but many of the speakers who are in interest group, they were also the part of some of the ESD interest group meeting also. So it means Diabetes India at this time was well presented in ESD, and we were also having our booth in ESD. So Diabetes India is closely working with ESD. With these few words, now I welcome our first speaker, Dr. Peter. I know that everyone in India, they know Peter. Who is he? He is currently president of International Diabetic Federation, but he is an honorary citizen of India now. We can call him multiple times, and we are really fortunate to have his great friendship that every time when he comes, we feel like we are calling our own friend, our own colleague, our own Indian friend. And that's what we call him. And we always ask him, sir, you have to take this lecture. So he immediately accepted. Today, our one more pleasure that we have two German speakers. Other is Dr. Manoj Chadda, who is trained in Germany and works like German and very close friend, senior endocrinologist, diabetologist based in Mumbai, a very big hospital, tertiary care hospital, into the hospital where he's working, attached where he's a professor of endocrinology, under whom DNB teaching program is also there. So without wasting much time, I will request first Peter to start. We have our panelists also, Dr. Ketan, Dr. Anuj, Dr. Brij Bakkar, and Dr. Vinay Randaria, who is going to chair. So with these words, I request Peter to start his talk, and that after his talk, immediately we can have 1-2 questions if there will be anything immediately. Otherwise, we will ask Manoj Chadda to talk, and then we will have panel discussion. We will request our speakers to stay with us because in panel discussion, we may require. Thank you. Thank you once again.
Yeah, dear Banji, dear Dr. Amit Gupta, dear Dr. Manoj and Dr. Maheshwari, I have seen. It's a great honor to be here again. And I must say, it's always a big, if I say fun, it's not the correct word. It's a big enthusiasm I experience if I'm in India and I see all the colleagues working in the diabetes sector. For me, truly, the innovation in diabetes care is in India. The environment is very different than in other regions in the world, but the passion, the enthusiasm, the energy, the innovation in diabetes care, this I always find in India. About myself, professor for prevention and care of diabetes, so I try to connect prevention and care of diabetes and learning from prevention for care and learning from care for prevention. This is where my heart is beating I'm currently the president of the International Diabetes Federation. So 242 member organizations or 242 diabetes organizations in the world. In every country in the world, there are only very few countries who are not member of IDF. And this covers more than 500 million people with diabetes. So it's an endeavor. It's an adventure in diabetes care. But what is driving me is to do whatever we can to improve quality of diabetes care in the way how it's delivered to the patients. The current situation is a challenge. Here you see 540 people on Facebook, and all the red ones will develop diabetes. So if you look at the slide, you can ask yourself, is it a lot or not? Yeah, this is the prevalence of diabetes in Europe. The prevalence in India is about 3 times higher. In Saudi Arabia, it's 6 times higher. So in Saudi, the picture would be totally red. But why I'm showing this? Because there are also the green ones. And the green ones are patients who walk through your door. You look at them and you say, this is a metabolic patient. So all your clinical experience, your gut feeling tells you, this is someone who must have diabetes or at least insulin resistance. And they have not. So this is a clientele of people who have all the risk factors, but not contracting the disease. And this is scientifically very interesting. Some of them say these are the healthy obese, and or they find different words, but they have something genetically or epigenetically in them preventing diabetes from development. And if we could dissect this, if we could explore this, we would have the secret answer to successful prevention of diabetes. And this is what is driving me to find or to work with a lot of research groups in the world to find this answer and to use it for diabetes prevention. But there are also different views onto diabetes. And why I'm showing this, because this was heavily discussed at the EASD. If you look at this slide, you may say this is the increase in prevalence of diabetes in the upcoming year, because this will be in Africa. We expect a 3 to 4-fold increase in diabetes prevalence in Africa. But it is not. It is the air pollution in the world today. And why I'm saying this, you know, Germany builds a lot of good cars, and some of them are diesel cars. And if you stay behind a diesel car and you take a deep breath, you find medium-sized particles out of the diesel engine 2 weeks later in your beta cell. If you ask, is it harmful to the beta cell? We don't know, because we cannot look into the pancreas and what it does if there are medium-sized particles incorporated in the islet and in the beta cell. But if you do it in cell culture, it impairs insulin secretion by about 30%. So this is interesting, because suddenly air pollution could become a relevant additional health determinant for contracting diabetes risk. And if you look into the map into India, there's also a high prevalence of air pollution. So this is something we have to consider if we think about global strategies against diabetes. But one of the big challenges is our physical inactivity. And these two numbers in my eyes are the good prevention of diabetes. If we would walk 10,000 steps a day, it's about 6 kilometers, we would reduce our risk in contracting diabetes significantly. And even if we have diabetes and we walk only 1,000 steps more than we normally do, it's 600 meters. It's not long. It lowers the postprandial blood sugar by 1.5 millimole. And this is what about the same what 2,000 milligram of metformin are doing. And for many of our patients, 2,000 milligram of metformin is the only diabetes management they are getting. So 600 meters walking has the same effect. So this, in my eyes, is very powerful information, because if you are honest, the true diabetology is not in our brain as diabetologists, it's not in our prescription, it's in the muscle of our patients. If we would be able to activate this muscle, and if we would be able to activate also our own muscle, because often we are not a good example to our patients if we talk about physical activity. But at the end, it's prevention and we could say prevention again. And for us as physicians, we are scientists, we are physiologists, and physiology is relevant. What you see here is healthy. This is a young woman, high normal A1C, but and the green arrows mean she's eating something, and she's eating a lot. She's always snacking, and the purple line is glucose. And you see, there's nothing. She is a person who is very insulin sensitive. So she may need only 1% of her insulin to regulate blood sugar, and she is normal glycemic. But here's her father. The father actually has a better A1C than the daughter, but you immediately see there is a difference in the glucose regulation. And the father is actually eating less carbs. That's why the better A1C. But this up and down of glucose, you see here before he wakes up, then after breakfast, after lunch, and then glucose is going down. Why I'm showing this? Because today we know that this fluctuation of glucose probably drives mortality and morbidity of our patient. So it's not absolutely, or in the future, we probably don't look anymore only onto A1C. We look at into the mean amplitude of glucose excursion over 24 hours, over 2 weeks, over a certain period of hours, and so on. And this will tell us more about glycemic condition, about cardiovascular risk, even about depressive behavior and so on. So the glucose curve in the future tells us a lot about morbidity and mortality of our patient. Problem is we don't find them. We cannot use a sensor for screening for everyone who has a BMI which is a little bit higher. But this will change. Already today, we find sensors close to $10 for 2 weeks. And I'm very sure in 5 years from now, we have sensors less than $1 for 2 weeks. And then it will be applicable to a large fraction of the population. And we have to think how to deal with this data, what to do with this data. So if you dive deeper into it, you see here the development of hyperglycemia, and here the blue curve, the development of insulin resistance. And the lady I showed you at the beginning is about here, with very low demand of insulin. The father is about here, and the difference to the father is very insulin resistant. The father needs about 80% of its insulin to regulate blood sugar, even if he has a better A1C than the daughter. But he is close to decompensate with the insulin metabolism. And only if the insulin secretion is going down, then hyperglycemia develops. So hyperglycemia is a late sign of a long pathophysiology, which probably starts 20 years ahead. And the trigger of this pathophysiology is visceral fat. And today we know there's one more, and this is hepatic fat. And if you look into the interplay between visceral fat, which starts very early, also in India, actually in India earlier than it is in Europe, and then later on, and this is about 80% insulin resistance where the father is, liver fat increases and then stays continuously at a high level and even accumulates more and more. And today we know the visceral fat makes us sick. The hepatic fat drives our mortality for us and our diabetes patient. Here diabetes starts and here we diagnose diabetes. So we come far too late. If we think about treatment of hyperglycemia, we are very, very late responder. We have to think about this red paradigm, whether we can act earlier to tackle the pathophysiology of diabetes development, because this would make a tremendous difference for our patient. And learning from pre-diabetes or prevention of diabetes for diabetes care, this is the concept of the future, I would say. And if we go deeper into the liver fat story and see, look at people who have no liver fat, and NAFLD is a synonym for liver fat, and those who have liver fat, and here's insulin sensitivity printed. The obese person who do not have liver fat has a better insulin sensitivity than the slim person, but having liver fat. And we all know this slim type 2 diabetes patient. And if you look into a country in the world where you find most of them, it's India. So this is part of the pathophysiology. I will not say this is the only part, but this is a significant part of the pathophysiology, but it's also a sort of big hope. If you look at Taylor, and Taylor was one of the main presenter at the EASD, if you have a lot of fat in the liver, you also have it in the pancreas, and this destroys better cell function. But also vice versa works. If you remove the fat out of the liver, you remove it also out of the pancreas, and you may restore better cell function and lead to a remission of diabetes. And this, I think, is the coolest information we have in diabetology in the last decade. And it may sound odd because all the new drugs, which are very good, which are excellent products, but for me, the idea of understanding the role of liver fat and developing strategies to remove the fat out of the liver is the biggest gain of health we can generate for our patients. And if I would ask you, what is the way to remove the fat out of the liver? The answer is very simple. It's fasting. If you fast for 2 weeks without eating any kilocalorie, and you heard it correctly, 2 weeks, 0 kilocalorie, you initiate a glucagon release already pretty early, and then glucagon is breaking down glycogen. But if the glycogen stores are empty, and this happens after about 3 days of total fasting, when the glucagon initiates protein breakdown or fat breakdown. And if you are physical active during fasting, the protein, the muscle is not broken down, fat is broken down. And glucagon is a fascinating hormone because it can initiate beta oxidation of fatty acids. And where is glucagon present? It's in the pancreas and the liver. So these are the first organs which are cleaned from fat. And this is the fastest gain of health we can generate. But we also have to understand where is it coming from. And this, one of the main things is the consumption of artificial sweetener. Here are 380,000 patients here on the slide. Drinking water doesn't mean anything for diabetes risk. Drinking orange juice, which is industrialized, prepared, it's 40%. Like Coke, like Diet Coke makes 60%. And this is because of the artificial sweetener, because they change the microbiome. Incorporating artificial sweetener, there are 38 artificial sweetener available, 36 do this, change the microbiome. The changed bacteria produce fatty acids as their stool, we could say, and they are highly saturated, and this saturated fatty acid, they get incorporated into the liver. And this is part of the problem, especially here in Europe. So the question is, how can we address this? And this was another hot topic on the EASD. And this is smart health and mobile health and digitalization. Here you see how our oral drugs lower A1C, how lifestyle lowers A1C, and how digital interventions, old, middle old, and young digital tools lower A1C. And now you could say, how can a young digital tool, which in most of the cases is a smartphone-based app, how can they lower A1C? It's not a drug. It's impossible. My answer is we are in the pocket of our patient. We never have been so close to our patient than being in the pocket. And every one of us is taking about 1,800 decisions a day. 450 are related to our lifestyle. Now imagine if we would, in the right moment, with the right motivational strategy, with the right content, only influence 10 out of the 450 decisions related to lifestyle, but do this over the period of a year, we may translate this into 10 kilograms of weight reduction. So digital health can be a bright future for diabetes care. And one of the goals I have as president of the International Diabetes Federation is being in the pocket of every diabetes patient, delivering diabetes education and delivering interventions for prevention and better care for our patients. And there are good examples, especially in Germany. Germany is in the moment in the forefront of embedding digital diabetes care into the disease management programs. And we use apps which are licensed as medical products and reimbursed by the healthcare system. Here's one app doing diabetes education. There's another one using AI where the people do photos from their food, what they are eating, and it's qualified and quantified. And this information is used to improve the intervention for nutritional coaching or here an app using glucose sensors and doing targeted nutritional coaching for people by the glucose curve, by the shape of the glucose curve. And another one, in my eyes, the diabetology out of the pocket of the patient. It's a Swedish development. It's again the sensor, and you have 6 areas of diabetes care. So oral drugs, insulin, physical activity, nutritional aspects, where the sensor curve is analyzed, 1,440 dots a day. And this data are compared to a swarm of 1,000 patients continuously tracking their daily life and using glucose sensors. And this app gives clear recommendation today at 6:35, inject 22 units of long-acting insulin. So this is basically our brain. And you may say, oh, this is bad, because what are we doing then as diabetologists? No, I don't think this is any problem. I'm thinking about Rwanda, 380,000 people with diabetes and 1 diabetologist. There are regions in the world with very low density, a low accessibility and availability of diabetes care, and this could be a solution. And the International Diabetes Federation wants to be one of the frontiers of it. Let me come to the fasting again. The fasting, in my eyes, is the best way of gaining health for our patient. And here you see an AGP from a patient after fasting, and you see such a diabetes patient after fasting. And you see the flat curve again, similar to what I have shown you at the beginning from the lady. And here's an MRI spectroscopy before fasting. And this cloudy stuff here in the liver is fat in the liver. And this is after the fasting. And I think it does not need more explanation to why fasting is so effective. And the International Diabetes Federation is currently developing a guideline for fasting and diabetes. And there are many Indian colleagues involved. And we learn a lot from India, especially from the fasting style of Hindus. And this guideline will come out in about 12 months, and 19 different styles of fasting are shown. But this is one, the 14 days total water diet or total fasting to abolish fat in the liver. And this is a proposal, what is on the metabolic side you can achieve. I will be the president, or I am the president of the International Diabetes Federation, and my heart beats for improving quality of diabetes care and doing whatever we can to discuss this, to bring different positions together, to share this information, but to translate them always in delivering better care for people with diabetes. And I'm inviting you to join this group and to follow our activities with me on LinkedIn here, Prof. Peter Schwarz, or Peter Schwarz for IDF on Instagram, or the WhatsApp channel, the closest way to follow the activities we are proposing, and also the ability to get directly connected to me. So a warm invitation to these channels. There are 3 goals what I'm having. Being in the diary of every healthcare politician, being in the pocket of every diabetes patient, and being in the heart of every diabetes care provider. And how to achieve this? One is we will develop a global diabetes index. So we will assess the quality of diabetes care once a year with 100,000 patients and 100,000 physicians. And then we bring this data together and translate it into an index. 100 would be the best delivery of diabetes care. We tested this in Europe, and the best country scoring in Europe is Sweden with 78. So there's no country achieving the 100. And the goal is to release this data free for World Diabetes Day, to motivate the politician in India, in Bangladesh, in China, in Japan, in Suriname, to think about the quality of diabetes care in comparison to the neighbor and maybe to change something. Secondly, to be in the pocket of every diabetes patient. We are on the way with Microsoft and Google to develop a global diabetes education program, which is available for free through these channels, through Google, YouTube, maybe at the end also TikTok, by reaching the people who have a smartphone, and to helping them to get a high quality, up-to-date diabetes education. And thirdly, to be in the heart of every healthcare professional or healthcare provider. And we will develop a fellowship program. And this fellowship program means then you, so I'm inviting you to become fellow of the International Diabetes Federation. We built a large community, a global community of healthcare professionals in the diabetes sector to share ideas, to share experience, and to get the best up-to-date evidence diabetes education and training. Because if you are a fellow of IDF, all the activities from the IDF School of Diabetes will be free to you. And there are in the future about 1,000 modules of courses for diabetes training to address those who think first time about diabetes care, but also those who are getting challenged with the 6 AID system and wants to know how to install the software. And the fellowship program will be the community for us, for you, and I hope that many colleagues from India join this activity. One of the other activities is the Diabetes Atlas, you may know, with the prevalence, and this will probably fuse with the index in the future. This QR code you can scan, and then you can put your email address into the form. And it doesn't mean that you register for the fellowship program, but you can express your interest. And then in about 6 weeks, so around the RSSDI meeting in India, we will invite you to the fellowship program of IDF. And this will become the IDF family in the future. We would love to see you at the Congress. But if you are not able, join these webinars like we are just doing now, join the fellowship program of IDF, join one of the social media challenges to stay connected with these activities. There are many faces of people with diabetes, and those activities we are planning, and I'm planning as the president of IDF, should put a smile on these faces, because I truly believe that these people deserve a better life. Again, the QR code, you're invited to the next Congress in Bangkok. And here are the social media channels again. And I would love to see you on Facebook, on LinkedIn, on Instagram, or the WhatsApp channel from IDF. So again, with the QR code for the fellowship program, I would like to express my sincere thanks to the cooperation with the colleagues in India, to the energy, the ideas, the activities I have the chance to experience in India. Because let me say it like this, for me as president of IDF, the colleagues from India and the passion and the enthusiasm is like a mentor for good quality of diabetes care. And this should be like this, helping our people to walk away from diabetes. Thank you very much for your attention.
Thank you, Dr. Peter. Again, a wonderful talk, very inspiring, motivating all of us to do more and more for the diabetes community. I will request Dr. Anuj Maheshwari, sir, if there are any questions, and then he can invite the next speaker also.
Thank you, Dr. Peter, for the wonderful talk. And it has really been discussed multiple times between you and me, as well as when Amit was there, that what the biggest challenge India is facing. And we reached to this conclusion that physical inactivity could be the biggest one. And apart from that, as you rightly said, the newer generation is very much used to of using sugary drinks and high calorie drink, as well as high carbohydrate diet, may be responsible up to certain extent for this upsurge of the diabetes, what you have very rightly mentioned in your presentation. So we can definitely have few of the questions. As far as the carbohydrate diet is concerned, it is not new for India. We have been using the carbohydrate diet since ages. Apart from that, of course, physical inactivity is definitely a new thing for us, and excessive use of the sugary drinks is also not new for us. Even in ancient time, this was being used very commonly when a person was going from one place to another place and going from one friend's home to the other friend's home. People used to offer them the sugary drink with the sweet dishes. And so calorie was never been a concern earlier. Now it has been a concern because we have been physically inactive. We are not utilizing what the carbohydrate we are consuming. Earlier, the idea remained that people, those who are going to the friend's house, going on walking, they are expending the calories. These calories are replenished by the offerings, whatever they received from there. But now, only thing is that we are getting the calories everywhere at our own house, at the friend's house, but not really doing any expenditure of the calories. And this is the biggest risk factor, which is making the epigenetically advent of the diabetes, in especially the type 2 diabetes in India. So this could be a very important food for thought. I'm seeing that there is a question, not question, there is no question as of now. I could see on the chat box. If any of my co-panelists may have any question or any idea or any comment, please, you are welcome to speak, sir.
So,
Dr.
sir, I
Makhtar.
think, sir. So I think, sir, we can, Makar sir, please.
Yeah, no, I think we can have questions at the end. That will be
Right.
best.
So
So,
over to Dr. Manoj Chadha for the another talk. Over to sir, please.
Thank you, Anuj. I think that was a really passionate talk by our president of IDF. Very, very impressive. I think in last 30 days, I've heard him for the third time, and each one he becomes more impressive and more passionate and drives home the point. So what I'm going to be discussing, when I started making the slides yesterday, I was telling myself what has happened in the last, say, 4 decades or so. And very interestingly, I put together some material from the EASD website. I just took the liberty of borrowing some material. And I'm going to talk what has been happening in the last, say, 3 decades very quickly, and then spend about 12 or 15 minutes in what we can hope for our patients in the, say, next few years. I won't say immediate near future, but in the next few years. So let me be very specific. I'm not going to be touching on the complications of diabetes. I think we have more discussions coming up in the next following days on type 1 diabetes, pathophysiology management, because this was extensively discussed during the EASD in different programs. Gestational diabetes, again, is a very, very hot topic because we keep talking about the fetal onset, the adult onset from the fetal stage. So that's very important. And the other hot topic at the EASD, and when we're looking at the future, was technology and diabetes management, which is, again, very fantastic. How the sensors are moving forward, the various types of pumps, the conversation between the sensor and the pump, the closing the loop. So these are very interesting things, but it's not going to be possible in the next 18, 20 minutes. So when I sat down to make this slide, so I was just thinking about what I have gone through as a student and then as a practitioner and as a teacher. So, we are looking at the pre-human insular era. We had talbutamide, chlorpropamide, glibenclamide, 2 or 3 types of insulins. And the whole idea was to control hyperglycemia. That's what we were taught in the 70s and the 80s. Around mid-80, we were introduced to human insulin, and we had the second generation sulfonylureas, gliclazide and glimepiride. And somewhere in the early 90s, we were introduced to glitazones, and there was a euphoria that finally we have a panacea for taking care of insulin resistance, and you're going to have a not cure, but a very good control. But troglitazone went out very fast, and rosiglitazone also followed within a few years because of its CV issues. Pioglitazone still stays around, but it's not a very popular product. I think things started moving very fast in the 2000 period when insulin analogs were introduced. We heard about the basal insulins, glargine, U100, detamir, and we moved away from the so-called dirty insulin to the insulin which was being manufactured in the laboratory. That's the time I think we were introduced to what is hypoglycemia unresponsiveness, because good control led to this and not because of the insulin which was initially being blamed. Fast forward to 2010. That's where we were introduced to DPP-4 inhibitors and a couple of years later on to SGLT2 inhibitors. And that has changed the management of diabetes forever. We have now so many options available for managing our diabetics. Not that they're doing better than what they were doing 30 years ago, but at least the options are available. And 2015 onwards, the post-EMPA-REG trial, multiple CV outcome trials, which from moving from neutral and non-inferior, we started talking about superiority of anti-diabetics, the SGLT2 inhibitors, the GLP-1 receptor analogs, and a whole lot of trials with the heart failure, with the kidney failure, the preservation of the functions, and then its importance in non-diabetics. So the whole scenario in the last, say, 7-8 years has belonged to SGLT2 inhibitors. We're still struggling to get GLP-1 receptor agonists into our armamentarium, primarily because of the daily injections and the exorbitant cost that our patients have to pay. So although we have the knowledge, but we are still not putting it into practice. But the point that I learned from the EASD meeting last week was that probably the future belongs to the incretins. So we are looking at modifications of this GLP receptor agonists. We are looking at dual receptor stimulants and whatnot. And that's what I'm going to be covering in the next few slides. But I came across this very interesting presentation from a young lady from Georgia, if I remember right, who spoke about the effect of alpha-lipoic acid in improving tolerance to liraglutide. This was something interesting because we know that our patients who are given GLP-1 receptor agonists, at least for the first few weeks, have a lot of GI disturbances. And just 600 milligrams of ALA in a small set of patients. We don't need to look into the whole historical thing, but we are quite familiar. But we know that besides neuropathy, where ALA is very useful, this study, which was 600 milligrams of ALA every day, looked at the various side effects and the standard nausea, vomiting, constipation, diarrhea, headache. Small set of patients, but interestingly, when we are comparing patients with liraglutide 3 milligrams, 2.4 milligrams, and 1.8 milligrams, the group which received ALA had a significant decrease in the side effects, and patients could tolerate and use more of the, the full dose of 3 milligrams and not stick at 1.2 or 1.8 milligrams. The nausea came down considerably, vomiting came down considerably, constipation improved, the headache was practically not there. So all in all, although let me tell you, she was troubled by the chairpersons, including Michael Lonk, and she had a bad time answering the questions and things like that. The other thing which was very interesting is, we know postprandial hypoglycemia, we know postprandial hyperglycemia, but this was a concept of postprandial hypotension. We are generally taught that after a meal, especially if it's a heavy meal, you should rest for 20-30 minutes and don't move around, because the circulation from the systemic moves to the splanchnic to improve the absorption of food. And if you have a rapid GI transit, the carbohydrates, the proteins would move down into the intestine, the absorption is happening, and that leads to a significant fall in blood pressure and an associated tachycardia. So that could be dangerous in patients who have underlying heart disease. So this was an interesting study on what is the effect of GIP and what is the effect of GIP antagonist in healthy older patients with a glucose load. So they are talking about a gut-heart axis now. And as I mentioned, gastric emptying can vary depending upon the type of meal that they are taking, and then the exposure of small intestine to the nutrients, and postprandial hemodynamics, as I said. And there were proper definition of postprandial hypotension, where the blood pressure can fall down by more than 20 millimeters, specifically the systolic blood pressure. And interestingly, they have even put numbers, 15% of healthy people and 35% of people above 65 years with type 2 diabetes. So this is of clinical importance. And as compared to placebo, if you're using GIP, it slows the gastric emptying. So you can understand that the blood pressure remains more stable as compared to placebo. The lixisenatide also at 10 micrograms single dose showed a similar effect of reducing gastric emptying and keeping the blood pressure stable. In terms of the use of GIP, which was again very interesting, the GIP, a GIP antagonist, which reduces GIP-induced insulin secretion, and placebo. So these were tried in 18 healthy participants. 13 were women and 5 were men, about 65, 70 years, with a body mass index of about 28, obese by our definition. And they were given, each one was given on 3 separate occasions, infusion of GIP, the GIP antagonist, and saline. And along with that, a 75-gram glucose drink, so a pure carbohydrate meal, calcium phytate radial able to find out the gastric emptying, and the automated measure of blood pressure. In terms of gastric emptying, all 3 did not make a significant change. However, if you look at what happened with the antagonist, the blood pressure was maintained. The heart rate did not increase with the antagonist, whereas it increased with GIP. The blood glucose, as expected with the antagonist, increased. So all in all, we have this theory into now being put into practice. And although we know that the endogenous GIP is connected with insulin secretion, but it also modulates the postprandial cardiovascular responses. Okay, let's go into the next thing. We are now on the verge of getting semaglutide injectable, tirzepatide injectable into the Indian market. So I'm not going to go into the pros and cons and side effects because you're going to hear a lot about it. But this is a network meta-analysis comparing the 3, liraglutide, semaglutide, and tirzepatide, and you will not get a head-to-head trial on this. But using the PCOS, participant intervention comparator placebo in most of these studies, the outcome, and these were randomized controlled trials, various permutations, combinations, huge number of records studied, 36 RCTs came out of it. Not surprising that tirzepatide 15 milligrams had the maximum weight loss, about 17%, and it went on reducing to about 4.8% with liraglutide. There was, no surprises in all this. Important thing is that at least 5% weight reduction, which we keep talking in terms of diabetes control and reducing complications, was achieved with a large fraction of these patients. We move quickly into the new things that are going to come up in this next decade. And from semaglutide to tirzepatide, and then we've got mazdutide, which has been studied in a phase 3 Chinese population, obesity and overweight population. I'm not going to go into the details, but the fact is 4 milligrams of 6 milligrams once a week brings about 18 to 20% weight reduction. In terms of waist circumference, also a good significant 10% weight reduction. We move on now to the triple receptor agonists. So GIP, GLP, and welcoming to the party is a glucagon receptor agonist also, which we are probably, it's called retatrutide, and it's gone into phase 3 now. And you will be hearing much more about this in the next 4-5 years. So it's a agonist of GIP, GLP, and glucagon receptors, binds to albumin and thus prolongs the half-life. And this study, not only looking at the A1C control and the weight reduction, but the cardiovascular determinants in terms of hsCRP, interleukin, TNF, adiponectin, these have also been studied, and all the factors work towards reducing CV risk. So in terms of body weight, A1C, things go improve. The hsCRP reduces within 20 weeks of therapy. The interleukin 6 goes down towards the end of treatment. Leptin also tends to go down. Adiponectin, which we know is the only poor hormone working alone to help insulin, also improves. So all in all, we can see that there are good cardiovascular outcomes that are expected with this triple agonist. As if that was not enough, you're hearing the first time now about a quadruple agonist. So we're looking at GLP-1, GIP, amylin, and calcitonin receptor modulators. Now, this is very interesting. The reason I brought this up was we keep talking about extreme weight loss, 15%, 20%. We are very happy about fat reduction, but we don't look at the muscle reduction. We don't look at the bone mass reduction, which obviously has to come up because there's rapid weight loss. And here there is now a discussion. These were initial just a rat experiment, but they're talking in terms of maintaining the body composition by using amylin and calcitonin as tools to help the GLP-1 and the GIP component. So they are going to work on the fat, they're going to work on the glycemic part, and amylin and calcitonin are going to work towards maintaining the calcium and the bone mass. So it's a busy slide, but I found it very interesting yesterday night. So that's why I have put it up here. And the EASD has been kind enough that those who are registered for the meeting can get the access today itself. But in the next 3 or 4 weeks, I think they're going to open it up to the public. So please make an attempt to go onto their website and look at these few studies that I've talked about, but just to whet your appetite and get you interested. I think Dr. Peter Schwartz has very, very categorically, emphatically, passionately talked about prevention. We learned that in school also, that it's much better than cure. But while we are still looking at preventing, I want to say there's a lot of hope for our diabetic patients. And with this, I'm going to stop sharing my slides and look forward to the panel discussion.
Thank you. Thank you, Dr. Manoj Chadha, for the nice talk. It has really been a very eye-opening revelation of many new things what we could see here. And very high-level panelists with us, Dr. Dr. Vinay Dandani, B.M. Makkar, and
Rajiv, you want to go first?
Amit Gupta.
Yeah, I think I have heard both of you. Both of you have clearly given merits and demerits. Early days also, if you remember, when me, Dr. Makkad and Dr. Madhu were at the Secretariat and Mr. Khanna, we were in touch with each other, and that time also we discussed this issue, and once I think, if I correctly remember, this was discussed in the EC also.
Makkad sir, can you please check your audio?
Hello, can you hear me?
Some voice is coming in the background. Everyone, please check your background. Is there some other meeting going on whose sound is coming in this meeting?
Is it from here?
Sir, I guess, yes. Yeah.
Dr. Rajiv Chawla was speaking?
Yes, yes.
Okay. So,
there was some other meeting happening, I think, in the background, right?
So Dr. Chawla would like to make some point here.
No, sir. He is not. Probably Dr. Makkar was attending some other meeting, and that voiceover was coming to this meeting.
Oh, that's I thought that he's making some comment for our meeting. Okay, very interesting. Good. So we can proceed.
Please proceed with the.
Yeah, Dr. Ketan Mehta, Dr. Brij Makkar, Dr. Vinay Dandania, three esteemed panelists, and with two wonderful speakers, Professor Peter Schwartz and Dr. Manoj Chadha. Before I go to Dr. Manoj Chadha and go to my panelists, there is one thing was coming to our mind as far as the India is concerned, and challenges of diabetes in India. Three things has been changed in last 30 years grossly. One is food, one is gadgets, or we have started using a lot of technology, And third is communication methods have been so much improved that we stopped using our body or our legs for the communication for going from one place to another. Which is the biggest challenge out of these three, which has really caused so much of advent of insulin resistance, type 2 diabetes in our day-to-day lifestyle, especially in Indian perspective. Would like to have a comment, a small comment from all the panelists before moving towards regular interaction. So over to Dr. Vinay Dhandani. I would like to start from Dr. Vinay Dhandani.
I, I learned. Good evening, everyone. It was really pleasure listening to both the lectures. And Professor Peter made a very clear statement that by the age of 22 years of 22, if you are not doing more than 10,000 steps, you are not preventing diabetes. So that is one physical inactivity at a very young age, which is happening in our country. I can give you a very simple algorithm which is happening. At the age of 15, our students are doing their matriculation, 10th. And 10th exam is very competitive. The moment the 10th is over, they are on a coaching institute, 11th and 12th for the competitive exams. And again, it is only studies and nothing else. Once the 12th is over, they are either into NET or IITs, whatever it is, they get into a institute, either engineering, medical college, another 5.5 years. So you can imagine from the age of 13 and 14 to the age of 25 till they are into a placement, they are not under any sort of physical activity except stress and competitive exams and getting into profession. This is where there is a very big turning point of physical inactivity and weight gain, both along with stress. And that is what we are seeing a lot of patients coming up with type 2 diabetes at the age of 25, 30, and 35. And this is what is going to be a new epidemic in our country, which is going on. So what Professor Peter says that 10,000 steps before the age of 22 is what is very important in preventing our diabetics. And he rightly said that fasting should be encouraged. It could be something like an intermittent fasting or a 10 days fasting or a 3 days fasting or a 7 days fasting. That is also very important to be promoted.
Ketan.
Yeah, good evening, everybody. I must admire Peter sir speaking on the subject, and we had opportunity to listen to him personally during DI session at EASD. So, what the main focus about is at targeting at pre-diabetes, which is the right group, because we have seen over a period of time that the population of pre-diabetics is much more than even diabetics, and probably that is the time if intervention can be done in terms of creating awareness and intervening in terms of changing the lifestyle, which will play a role. Now what is happening is, if you see during the youth, or especially in early adulthood, where we see nowadays more of pre-diabetes, they get tempted towards the celebrities, be it from Hollywood, Bollywood, cricket, or FIFA, or all those. And those celebrities will do branding for something which is absolutely unhealthy, be it for a cola drink, be it for chips which are fried items and all. If these celebrities come forward and they do a proper awareness about that these are bad and these are good thing, I'm sure that will go a long way. Second thing is about the physical activities. Good old times, people were promoting for physical activities. Now more of promotion is coming for various apps and playstations, that, oh, you want to play FIFA or football or cricket, you've got option, you go to mobile and app and play the games. So that's not the one which is there. Probably that also needs to be targeted more upon. So wherever we are going to digitalization, physical activity should not convert into digitalization. That is what is most important over here. Thank you.
Doctor sir.
Thank you for having me, first of all. And my apologies, I didn't know that, my phone meeting was also connected through my headphones, and this meeting was also going on. So I couldn't, disconnect that for a while. Anyways, So, if you look at, why suddenly we have increased prevalence of diabetes and obesity, I think we have to learn from two large famines which we have seen. One is the Dutch famine, which occurred around, I think, 40s end. Peter will be knowing better about this. This was during World War. And the women who were exposed to famine that time, the children born to those women had, higher insulin resistance, had developed all kind of diabetes and atherosclerotic cardiovascular risk by the age of 50s and late 50s. And then we had Chinese famine, which was in, I think, towards the end of 60. And again, the children born during that famine also showed the early rise of, insulin resistance and obesity. And I think this is a lot to do with the one is the intrauterine programming of the baby and how the child baby is exposed to the environment. Of course, there are genetic factors, and we have, bad ethnicity also. We have so-called Asian Indian phenotype, but there is a lot of contribution coming from the epigenetic factors, the environmental factors, the exposure to the malnutrition in the intrauterine life, which I think still is going on in India. We still have 20% population who's malnourished, and there is impact on the mother's health and also indirectly on child health. And if you are, that we recently had met the President of India and presented a white paper on focusing on female child health. That will be the only way that we can look at prevention of diabetes after maybe 20 years. So all female children in the young age, maybe 10, 12, 14 years, who are going to become adult women should have good health, and that will make the health of children who will be born after 10, 15 years very different from what we are seeing now. Of course, there are multiple factors. The environment is one, rapid, mechanization is one, lack of physical activity. All those factors are there. But I think uh, we are looking only at some factors which are too visible. I think there are bigger, challenges that we are facing, and that is why we are seeing large, population having obesity now. Another problem is we are not focusing at obesity as a disease. We are looking at numbers of 101 million people living with diabetes. We are not looking at numbers of 300 million people living with obesity, or 30% people living with obesity in adult population overall, 40% living with obesity in urban population. And these are all people who are going to get, diabetes and cardiovascular disease. So I think a lot needs to be done on prevention part. And I congratulate Peter, the way he is passionate about educating about creating education about diabetes and focusing on prevention of diabetes. I think that is the way to go in future.
Thank you, Dr. Bakkar. Dr. Manoj Chadha, would you like to comment?
Not really. I think we've heard the whole lot.
Yes. So move to the another. Yeah, when Dr. Vinay wants to make some point.
The first slide which Professor Peter started was with Mercedes and diesel Mercedes and the pollutants which are being emitted through the Mercedes is creating a lot of environmental pollution. I think that is also one very big factor which has changed in our country, and environmental pollution could be one of the impact which is creating in the new onset of pre-diabetes and diabetes in our country as well. At the same time, in the farming, we see a lot of patients coming from even rural India at a very young age with higher blood sugar and very, very lean and thin people coming with high diabetes. This could be again uses of, they are using pesticides and they are using insecticides at a very, very rampantly without any guidance of using an appropriate doses in the farming. So that could be another area of concern, like organic farming and training of farming at the level of agriculture. That is also going to be a very important factor in prevention of diabetes. in near future or maybe right now.
But Vinay, I would like to make a comment here. I think if you look at the current data over last 20 years, the strongest driver for increasing prevalence of diabetes is obesity.
Agreed, sir.
This is the factor we understand.
Agreed, sir.
The pollution, the environmental disruptors, the endocrine disruptors, we are just starting to understand. But I think the biggest challenge that we have in front of us is obesity, which we understand much better, and we know that we should focus on it. That should be the first point to hit on to cut down the prevalence of diabetes.
Amit, you want to say something?
Sir, I want to make one point. Excellent presentation by Dr. Peter and very well summarized by Dr. Manoj Chadha, what what we learned in the ESD. I have two critical questions, and you know that the number of risk factors for the diabetes over the last 2-3 decades, they have only increased. We all talk about digitalization, but we know that digitalization has come at the cost of reduced physical activity. And I am worried with the advent of artificial intelligence, even we are going to use less of our mind as well. What is going to happen 25 years from now? We are already compromised with reduced physical activity. Mental faculties are also being utilized less and less in the era of artificial intelligence. Number of sectors of the thing. So where are we actually?
Peter, you would like to make some comment?
I must say I'm actually still stuck at the very first question. What is the major determinant or contributor to diabetes development in India? Is it physical activity? Is it digitalization? Or is it the dietary habit? And even if I'm a strong fighter or warrior for physical activity, I actually would say on the population level, it's the dietary habit in India which is driving the development of diabetes. And I want to argue why. There are more and more studies who analyze if you fry carbs at a very high temperature of oil. So it's more than 130 degree of the oil. And if you then fry carbs, you develop bonds between fatty acids and glucose, which your body cannot break. And if you then eat this fried carbs, it gets accumulated to the liver. So I think that the habit of frying carbs, even if you use veggies, but you use a panade of with carbs, this is one of the main contributor of the very early increase of diabetes risk. And what we are seeing in India is that the period of pre-diabetes is much shorter than it is in North America, than in Europe. And I think this is a progressive destruction of the beta cell in an environment of heavy insulin resistance. And I would say the main determinant is the consumption of fried carbs. It's still a hypothesis, but there are a lot of arguments for this. And so I would say the main thing to tackle this is frying at a lower temperature, or using the hot air fryers, or thinking about dietary intervention, and then using digitalization again for dietary interventions.
Very right. Very nice comments, what you said about the Indian situation. Although we can summarize all these things, everybody is right at their own end. But one thing, another arises in the mind once we listen Dr. Manoj Chadha summarization of the learning from EASD. If we start from the advancement in the management of the diabetes, it's what is the most available information is from the advent of the insulin in 1921. And since then, about 100 years or 102 years, 3 years has been the fastest growth in the advancement has been in the last 20-25 years. But the similar level of the growth has been in the diabetes patient and prevalence also, as well as complications has also grown at the same pace what we could really develop or we could really invent the armamentarium or tools in our armamentarium what we used against diabetes. So can we really match this thing, or can we find some reason, or can we correlate this phenomena, that why did it happen when we were getting more and more tools to fight against the diabetes? Dr. Manoj Chetna, would like to have your comments and others.
Yeah, I think you got a very valid point that we seem to be keeping pace with the developments, and somewhere you have to break this chain. I think all the panelists, including Peter, have insisted that we need to increase the lifestyle. See, the only thing is, if you look at what our grandparents were having diet, it was definitely more rich. It was definitely heavier than what we are having, but probably the activity part took care of it. And remember, our forefathers were having desi ghee. There was nothing like oil that was used in those days. And today also, I think in North India, uh, I know, for example, in my sister's house, using oil is considered very poor.
So for
So
Peter's information, the ghee is butter oil. Butter oil. You make oil from butter.
the cream of the milk. Yeah,
You
I
are
think
you
You
are
were
this
saying
is
something,
the
Manoj.
nutshell that we are fighting a battle, and if you have to win, as Peter said, somewhere the diet, the activity has to outpace the increase in number of cases.
Let me do a very short comment, and this is related to Germany. If we analyze our habits in the last 100 years, interestingly, we don't eat more calorie than 100 years ago. This is actually odds. Yeah, we often argue that we eat too much, but 100 years ago we have eaten about the same amount of calorie. But the quality of food has changed a lot, and actually it went down because of fast food and because of industrialized food production, uh, at least in Europe. But the main driver of risk is that our physical activity was about 2,800 to 3,000 kilocalories 100 years ago, and now it's between 600 to 800. So we have reduced our physical activity by 70% over the 100 years. And of course, this pushes the development of metabolic risk factors. So at the end, it's a very logical consequence why we are getting sick. But it also tells us what we can do to walk away from diabetes.
Anybody would like to make any comments on the same? Dr. Makkar.
I think most of the points have been discussed, but ultimately what we understand is that there is no shortcut to lifestyle interventions. And I fully, I am fully convinced. In fact, with my every prescription of mine has elaborate instructions about lifestyle intervention, because I think if you are not putting lifestyle interventions in place, you are actually not doing justice to the patient. They have to understand that increasing physical activity, not saying that you have to exercise, they have to cut down the inactivity. They have to increase physical activity and moderate their diet and make sure they are at least not gaining weight. At least if they are not losing weight, they are not gaining weight. That should also help in cutting down the burden of cardiometabolic risk.
And you
Makkar
will
sir,
agree, sir? Yes. Amit, you want to say?
Anuj sir, very nice comment by Dr. Makkar sir. And it just reminds me the our session at the school, which we did with Dr. Peter Swartz. And Dr. Peters just mentioned that what you can do to walk away from diabetes, and it is just to walk. You start walking and you can walk away from diabetes. And he actually demonstrated to the children by running himself that if you want to run away from metabolic disorders, you need to run. So I think the solution is very simple, but the key challenge is how to make people walk. So
The
this is
problem
what I
is it is too simple to understand.
yes. So Dr. Anush Meshri was also there, and Dr. Peter actually demonstrated that to run from diabetes, you need to run. Yeah.
And in fact, what Dr. Manoj Chakha was saying, I also can take one more example of the similar kind of the thing. We all were having lot of consumption of the desi ghee, which is available from the milk and milk products earlier when we were in childhood. But suddenly in 1990 and 1991, a drive has come up and everybody's kitchen has been devoid of the ghee kind of the things and oil has replaced that. At that time, I don't know what was there was some excess of the palm oil in across the world, and that's why there was a necessity to sell that. But it was said that now cardiovascular uh, adverse effects or now the cardiovascular events would be lesser because now you stop using the animal fat. But after that, what we have seen, cardiovascular events has increased like anything, despite we are not using fat in our kitchen. We are neither using the vegetable fat, neither using the animal fat. We're using very little oil in our kitchen. But still the cardiovascular events are increasing. Earlier we were having only one center for the cardiac catheterization in Delhi. Now we are having every city is having one or two centers of the cardiac catheterization. So this is a change. So we must have some thought that why did we get this kind of the development and where we really remained on the fault to understand the realities, to understand the real situation. Dr. Bansi has also joined, would like to have if he is having something in his mind about the both conversation.
So, I mean, you were saying, Anuj, that there are many cardiac centers which are open across the country. But I always say that we endocrinologists are actually poor, and our interventional cardiologist friends are really very rich, and they understand the disease much more better than us. They started teaching each and every patient that this is the stent which they have to use and which is costing 1.5 lakhs to 2.5 lakhs rupees. And this is the price of their intervention also. While we diabetologists could not explain our patient for a simple thing, which is like a continuous glucose monitoring, which is costing only $50 or around 44,000 rupees for a continuous glucose monitoring. So actually, it's mean that our patients are not poor. It is the diabetologists who are poor. They could not explain their patients properly. They could not teach, all across the country. Peter is laughing, but across the country now, there are thousands knee replacement center, or maybe 10,000 knee replacement center in India. Maybe 100,000 coronary cath labs are there. And every year we get 1,000 DM cardiologists, which is intervention cardiologists. But we people are not, accepting the newer technology. Are people who are getting cataract surgery. I remember in my childhood, the Rotary Club used to get for free of charge for everyone. And today, a one cataract surgery is costing in India around 1.5 lakhs to 2 lakhs rupees. So this is how the things are changing. And I always see that whenever I talk in any diabetes meeting, people start saying that we are poor, we can't use these newer things. Our patients will not afford it. Come on. 20% of our patients can afford anything which is available in the world, even which a German can't afford, we Indians are affording. So it's not like that. And why we are always crying that people are not able to afford? Why people go for these cardiologists and why they get the intervention, why they go for the nephrologist? Because we could not take care of them properly. When they were us, they were at our point. I mean, Bakkar was talking about the obesity. We could not manage the obesity. That's the reason now they develop all complication. They develop even osteoarthritis in young age and they are getting knee replacement. We could not manage their smoking cessation and we could not manage their diabetes well, and that's the reason they are renal failure in cardiac patients. We could not get even their lipid profile, which is as per we made the guideline. We are the one who made the guideline. And our patients' lipids are keeping LDL more than 100, while it should be less than 70 and 50, which is not there. And that's the reason they develop all coronary events. So these events can definitely be prevented. Only thing is we need intensive education and we need aggressive education. So I always we should call ourselves also interventional diabetologists rather than just diabetologists. We have to do more intervention for our patients. I mean, I was slightly in between, so I don't know before that what discussion was. Sorry for that.
Very rightly said.
Peter wants to say something.
Yes.
Peter,
Peter, you want to make some comments?
Yeah, you see me smiling. I'm totally agree with what Banshi just have said. The idea to become interventional diabetologist, this is actually a cool strategy. But we should not blame our colleagues for not being so active, but we know the environment, we know the pathophysiology, we know the physiologies. So it's on us to enhance the educational opportunities, to train our colleagues, to build CME programs like you just do here, and to infuse this knowledge into the brain of our future interventional diabetologists. And this is one of the strategies we want to go with the fellowship program. So again, the invitation to become fellow of the International Diabetes Federation. And to remind you, actually today, 74 years ago, the International Diabetes Federation was founded. It happened today. And
So we will
I
make,
think
one announcement today only, tomorrow, that 74 years of IDF is completed.
this is cool.
And we are going
This
in
is very good.
75th year under Dr.
And
Peter Schwartz.
I think this is a very good moment also to say, okay, this organization was founded, and let's use this platform to come together to tackle exactly the problem Banshi has mentioned. So thank you very much for this.
Thank you. Thank you all panelists for your valuable comments. Now over to Amit Gupta for vote of thanks.
So I would like to thank President of IDF, Dr. Swartz, Dr. Manoj Chadha, our moderator, Dr. Anuj Maheshwari, Dr. Sir, Ani, and Dr. K. Panelists. And I think we did not actually remember that today is the foundation day of IDF, but I think God is very kind to us, and we are fortunate to have and celebrate this foundation day with Dr. Peter Swartz in his august presence. I think this is, and all of those who are listening to this, let me just share, Dr. Peter Swartz has formed his WhatsApp channel, and he is very keen to have all of you connected with him on this channel so that he can post regular updates. And we have posted that link in the audience chat box also. We will be sending it to the email also. And before I conclude, final remark is always from Dr. Bansi sir, so I will request him to conclude the program.
So, I got the slightly, in my mind, there was an idea came that today we are making the foundation day sort of thing. I remember, as far as it is, Professor Dr. Lawrence was the first president. Am I right, Peter? And he was the type 1 diabetic himself. And he was one of the first person from UK who got the insulin also. So I don't know history properly, but I think today we should try to get the history properly again and to write it on our Facebook page, on social media page, on Peter channel also, on everywhere we should write about it. And tomorrow Amit will put it everywhere, I'm sure. It will be there across the world. Everybody will know it in LinkedIn, in all other news channel, it will be available. But this is one thought, and that we can also think of, IDF does not have any oration or some honor lecture. We can think of putting a honor lecture on the name of Professor Dr. Lawrence also, as his name is nowhere written anywhere, no association, neither Diabetes UK nor any other international organization is making his name, and because he is the one who had thought of inviting all over the world organization, all world organization under one platform before 74 years. So I think he should be remembered in different parts of the world, and at least by International Diabetic Federation, to keep on his name as an honor lecture. So this is my just request. You can always give this honor lecture to the best person, best scientist, like Benting lecture is given in ADA, the similar lectures can be created for them. So this is just a thought, and I'm thanking each one of you once again. And thank you, Peter, for joining. It's an afternoon or evening time. For us, it's late evening. It's 10 p.m. And Dr. Makkar Sahib is sending just dinner to everyone. So I'm just waiting for my dinner. Which hotel he had ordered, I don't know. And for you, Peter, he will be sending wine. Thank you. Thank you once again.
I am sending by drones.
Just add one more thing about Dr. Lawrence. We discussed about Dr. Lawrence at so, and we discussed that he was the person who actually received first one of the the insulin injections.
So that is what I told you, that is he was in 1923, he got and first person from UK to get it. And then he lived for another 30, 40 years. He was a
Yes.
medical student when he developed diabetes.
Yeah.
This is the story I remember, but still we will find it perfectly. And
Yes.
then, right?
You're right. So we
Thank
close the
Okay.
session today, and we request everyone to log in again tomorrow as we bring more updates from the ESD tomorrow.
And requesting all panelists to also log in tomorrow. You can be
Sure.
there in the faculty list, even the audience may be more, and we will have more discussion. So that's my request to everyone. Thank you.
Sure. Thank you. Good
Thank
night.
you. Thank
Good
you.
night.
Bye. Bye.
Okay, thank you. Good night.
Right.